I think it's huge to kind of like, okay, what does this patient need from me? Do they need me to be, the super assertive, like, this is what we're going to do, or, do they just need to vent and they need you to sit down in the room for a minute and just let them kind of be heard? Or, do they need a mom? Do they need a mom voice to stop making poor life choices? Or do they need you to be their friend from AA? Like,
Hello, and welcome to the Art of Emergency Nursing podcast. This is where we share stories for inspiration, entertainment, and encouragement, because we all know emergency nurses have the best stories. Now here's your host, Kevin McFarland.
Hey everybody, hope you enjoyed the episode last week with Jessica. I decided to bring Jessica back this week so you guys can find out a little bit more about her. I think you're going to enjoy this episode. I got a lot of feedback from the last episode, so I appreciate you guys chiming in. Remember that you can follow us on Facebook and share your thoughts about the episodes with the rest of the audience, or you can email me. My email address is on our website at www.artofemergencynursing.com. Enjoy this week's episode with my guest, Jessica.
I said, yeah, Amanda Sandoval's, like, the episode title was Be the Duck. I'm like, oh, mine is going to be the Lunatic.
That's a great
Be
title.
the Lunatic.
Great title.
It's like, oh my God,
title.
babe.
It's kind of funny, the titles of these episodes. As I'm just kind of going along, like something just sticks out, and I'm like, oh, okay, yeah, there you go. There's the title. There it is.
Yeah, but it is. It's kind of interesting. I mean, I'll talk to my family about some of these stories, and they, no one believes that I was such a quiet, like, reserved, like, very shy little girl that cared way too much what other people thought about me. And I think now I joke, I'm like, oh, I'm just, swinging a little back in the other direction.
When did it change? Was it nursing that caused that change?
Yeah, definitely. Like, becoming a ER nurse, like, really helped me find ownership of my voice and who I was and what, what I saw. And
because you don't have a choice.
Yeah, you have to, right? Like, I couldn't do it. And granted, like, I was only in my 20s when I came to nursing, but, like, so it's like, well, yeah, if you can't do it for yourself necessarily, like, it's hard, but you do it for someone else, no problem.
Isn't that funny? Isn't that funny how we, we'll take it in the chin, if it's just us, but if it's, if it's, hey, I got to stand up for my coworkers, my patient, my whatever.
Yeah.
Then we like take it a little bit more seriously. Like, well,
right.
I can take it on the chin, but she shouldn't have to take it on the chin.
Yeah. Yeah. And yeah, so I think it's one of those things like, okay, you can probably stand up for yourself like this too, Jess. Maybe, I don't know. It's funny. I think one of the questions you tend to ask, because I was just kind of mulling over and thinking, was about, like, what advice you would have to newer nurses.
Yeah.
And I think, the thing that completely comes to mind is, like, the whole, like, you see something, you say something.
Yeah.
Because we've all had those times that we didn't say something, and not that we were necessarily right, but we should have. And if we had spoken up, even if we didn't quite know what was going on or what was the answer, it might have helped care for that patient better,
It's one of those where I don't know the answer, but this isn't it.
Mm-hmm. Yeah. Yeah. There's something else here.
Did you have a time like that? Can you think of a time that you should have and didn't?
Well, let me tell you about a time that I was witness to that.
Okay.
This I think is why this is what really drove that home, that whole see something, say something for me, because it was at another hospital, regional medical center up in Santa Fe, and I was at that dangerous, like, 2.5 years in the ER, where enough that you get through most shifts and comfortably, but man, like, if you're not really comfortable or careful, if you get too comfortable, and you're not very humble, I mean, I call them, like, come to Jesus moments, where you're like, oh, whoa, I was on the wrong page, and that could have gone so bad.
Yeah, you're like,
Huh?
Yeah, you're like, I don't know what I'm really doing yet.
Yeah. I don't even know why I think I do. Or like, I felt like I came into work and like I was halfway competent. But nope, I just need to remember this moment.
Yeah.
Knocks you down a little bit. But I think those are really important moments. So I was about 2.5 years in, and I was orienting a nurse that I don't know if she was new to the ER, but if she had worked in the ER, she had worked in a very small emergency room, and her name was Kimmy, and she's from Cuesta, and she just is, I don't know, not even 5 foot, and just quintessential like northern New Mexican, and she and I were taking care of this 40 to 50-year-old male. And I think he came in with kind of a cardiac or shortness of breath complaints.
Mm-hmm.
Just having like, I don't feel like I can take a deep breath, and my chest hurts, and he had that impending doom, like something bad is going to happen. And he said that multiple times. And he did have, his only history was a history of anxiety. So he went back to one of our cardiac rooms, and like, long story short, we did the whole chest pain, shortness, breath workup. Like, he was tachy, but otherwise the vitals were okay. First troponin was completely negative. EKG was unremarkable. 4 hours later, like, second troponin still 0.
Huh.
EKG looked the same, just nothing special. And this patient was by this time, I think it was the middle of the night. It was like 1, 2 a.m. And he wouldn't stay on the monitor. Like, I remember being like, oh my gosh, this guy is going to be the death of me, he was so anxious, and he just wanted to pace the room, and he wouldn't stay on anything, but everything was coming back that this was simply like, a really, psych or something. So personally, I was like, okay, it is time to advocate for some Ativan for this man. And I had kind of, I was orienting Kimmy, but I was just kind of like, okay, you run with this one.
Yeah.
I am no longer interested. And so horrible. But he was just getting on my last nerve. But he kept, something bad's about to happen. I know it. And then Kimmy comes to me, I remember, and she goes, I think I'm going to order another EKG. I was like, okay.
All right. Like,
your prerogative, Kimmy. You do what you want. And oh my gosh, he had just massive elevation in the anterior leads. I think that third troponin we drew,
like,
whatever,
through the roof.
Through the roof. Yeah, and the other reason it was so memorable is, like, Kimmy came to me with this EKG, and where we work, there was only one physician for the whole ER at night. And they weren't really they were probably in a room across the ER, so we didn't know where they were, but I knew what I was looking at was horribly bad. And so we hooked him up to the pads, and then he went to a VFib arrest, and
Holy
it was the
cow.
first time I've ever done ACLS by without someone holding my hand.
Yeah.
So when we shocked him out of it twice, enough that he would come to and he'd be like, where did I go? And I just remember being like, oh, I don't know.
Oh, we don't know where you went.
I
You
don't
tell
know,
us.
but stop. And so then he went to the cath lab and had 100% occlusion of his LID. And so for me, that was like, Kimmy saved that dude completely. Like, because she listened, I didn't have that feeling. It's not like I was feeling like something was wrong and I didn't listen to it, but she did. And she, even though I was kind of just rolling my eyes at her, like, want to order fifth EKG, she completely saved his life. Because he wouldn't stay on the monitor for me, Kevin. I mean, it was just like, I would have found him collapsed in the corner or something.
Right. Found him like crumped in a corner, like, oh,
yeah. So that for me was really that whole, like, man, you have to stick by, even when people are rolling their eyes or not listening to you or thinking like, yeah, why don't you ask for some Ativan too in addition to that EKG order? Like,
Yeah.
don't listen to them, you know?
Yeah, there's no reason. I mean, just do it.
Yeah. Yeah, and I think at the end of the day, you know, you'll do better, because then you know that you did, you know, you stayed true to yourself and did what you could.
Yeah.
And it's like, it's so ingrained in me now. Like, I often say, like, you see something, you say something.
Yeah.
The worst thing is you'll look silly. The best thing is you'll notice something that someone hasn't, and you'll actually make a difference. But usually you'll always learn something, you know. So it's so win-win. And it's kind of become so ingrained that even now, you know, like within this last year, it was a trauma patient that he got intubated kind of like right between that primary and secondary assessment.
Yeah.
So primary was done, gave him RSI, got, you know, bunch of rock, and I can't remember if it was ketamine or etomidate, and then we went on to the secondary, and I happened to be on the posterior end when they rolled him, and I think that is so, you know, I've just ingrained myself with that. Like, see something, say something, that in the middle of the trauma room with, you know, 50 people in the room, I'm like, oh goodness, like, are we worried about spinal cord injury? Because he has no rectal tone. And then before it could even come out of my mouth, everyone's like, yeah, Jess, we gave him a bunch of rock. I was like, oh yes.
That'll do it.
All right. Well, I look silly, but but I would rather look silly 1,000 times and just make that difference that one time.
Yeah, I'll take that all the time.
All the time. Yeah.
When I was a brand new baby nurse, it was one of my first shifts when I was off orientation in the pediatric ED. And there was a doc that I used to work with named Dr. Oswald. And Dr. Oswald was like the chair. He was like an associate dean. He was like, you know, the grand poobah of emergency docs, right? Mm-hmm. So he sees this kid and he tells this kid, he goes, oh yeah, this kid's ready to go. And I'm like, I don't think so. I'm like, he still doesn't look that great. And he was like, and Dr. Oswald's like, well, what do you want to do? I was like, let's give him another bolus and see if that helps. Because the kid still was like not doing well. He wasn't running around. He wasn't like active. He just didn't look great yet. Mm-hmm. But it was one of those things that I felt like I had to stand up and say no. And it was hard. It was hard as a brand new baby nurse to go against the attending and say, hey, I know you think this guy's ready to go, but I don't think he is. But I did it, and you know, we gave the kid some fluids, and he of course looked much better by the time we finally did let him go. But even early on in my career, I was encouraged by my preceptor, who, you know, was fabulous, Sarah Dakin, who you know.
Yes.
Who was fabulous. And she's like, if you're not comfortable, then you just say no.
Mm-hmm.
And you're like, it's just, you got to stand up and say stuff.
Yeah. It's not, it's those times where you know that you said something and made a difference. Like, that is fills you up so much more than all the little times where you say something or maybe you made a fuss but you were completely wrong. Like, I don't remember most of those. You know? Yeah,
you're like, yeah. Have I made mistakes? Oh, sure, plenty.
Oh yeah, lots and lots. But you know, that one, the ETOHer that everyone knows, and oh God, he's just drunk. And it's like, well, is he? No. Well, I don't know. He's got this, you know, abrasion on his forehead and his hands, and let's just scan his head. Oh, he was here yesterday or earlier today, whatever. You know, and then they fell and had a subdural. It's like, yes, like that, you know. That makes that's so horrible. Yes, they have a subdural, but you know, I just
score.
I love that feeling when you can advocate for someone who can't. And
I mean, that's what we do as nurses. We advocate for the patient. And,
yeah,
I mean, when you look at the amount of time that we spend with the patient versus what the doctor spends with the patient, and that's not a slam on doctors. I mean, they're completely overwhelmed. Mm-hmm. But like, and that's why the doctors listen. And that's why the doctors are like, you know, if the nurse comes up and says, hey, I have a concern, the doctor's like, all right, let's pay attention to that. And any doctor that doesn't just, you know, does so at their own peril. But it's just it's just what you got to do.
Yeah.
So
I think that's always something that's good for newer nurses. It's hard. I mean, yeah, no one, you come into an environment, you already, it's so overwhelming. You feel so like such a fish out of water, but you really have to vocalize that, because if you're not getting the picture, if something doesn't make sense, then, you know, it's either a knowledge gap or on your side, and it's something that you can identify, and then also kind of, like I said, you'll always learn something. What this puzzle am I missing? Or or even as a new nurse, like, yeah, you very well could just have caught something that no one else did.
Absolutely. How long have you been a nurse, Jess?
How long have I been a nurse? So 9 years.
9 years. That's a while. You got some
it feels
time
longer in some ways.
feels like 20, but it's only been 9.
I know. And I also my first degree is in psychology and Spanish, and I kind of quickly realized I couldn't.
Did you realize you needed
do all
a job?
that much?
Yeah. Then you realized you still needed a job after all.
Yeah, with my Bachelor of Arts. So, but I did actually with that. When I was doing that degree, I worked in a little while after I got in with the University of Colorado with their Department of Psychiatry, and I was working as a clinical research coordinator. So we would go to the Denver Health ER and the psych unit at the university to kind of check in with study patients or recruit for the various studies. And I was like, oh, this is so awesome. And I kind of fell in love with just the idea of the pathological cause of mental illness versus I just loved that it was something tangible. And I initially thought I wanted to go to medical school, but then working there, I was like, well, the nurses are the ones that actually get to see all of this and be part of it.
I always hear that. You always hear wow, like people who go spend time in the hospital, like, oh, the nurses have a way better job.
Yeah. Right? I'm like, oh, they get to they get to talk to the floridly psychotic person and become part of their delusion. The doctor comes by once during the day. So I really gained appreciation for what they do, and times I would go into Denver General and just see the ER nurses. I was like, yeah, this is totally my jam.
How do you think your degree in psychology helped you as a nurse, as an ER nurse specifically?
I think just human relation type stuff. So we'll do a lot of the trainings on AIDIT, or just how to speak to someone who's not in a rational state. And I think some of that just feels kind of intuitive, just from my 4-year degree.
Yeah.
I think any ER nurse that's done this for a couple of years, probably gets an unofficial degree in psychology.
I was gonna say they should get an honorary degree in psychology.
Here's a bachelor's of art, honorary bachelor's of art in psychology.
Here,
you're not gonna necessarily do anything with it, but yeah.
you get crazy. You understand crazy. Here's a pat on the head and an honorary degree.
Totally. So I think it definitely hasn't been a hindrance, and
yeah, that's good. That's a good thing. So, tell me about a patient that changed the way you practice.
This, I could definitely use that same story,
Sure.
story. There was another, there's, speaking of behavioral health, I guess, there was a patient that, I was really brand new. and actually I've written a little story on this, if it sounds familiar to anyone, because I know some people have read it. But I was brand new in the emergency department, and I was off, the 6 or whatever 4 months orientation, but I was still so green. And they, it was a really busy night, and we had, it was probably full moon and everything in retrograde. But this woman came in who, she was so tiny, and she was she was somewhat a frequent flyer. She'd disappear for a couple months, but then we'd see her frequently, a couple times a week. And she would just tended to be so angry. Like, she just always came in restrained. She'd be intoxicated. She'd be restrained. She'd have a spit mask. She'd have to be completely sedated and knocked down before, and then she'd be okay when she woke up 6 hours later.
It's funny how that happens.
Right?
A little sleep does everybody good.
Right? Like, just, a little bit of memes and wake up normal. So, or relatively. So this, my charge nurse had kind of, probably thought this was a good learning opportunity for a new nurse, and he sent me in the room, in the, the locked room, to give her the B-52.
Wow.
And it was,
way to throw the new kid under the bus.
Totally. Yeah, he was good at that. I learned a lot from him, though. It's funny, you look back and you're like, oh my gosh, at the time I felt so abandoned. Like, I felt like I was just tossed under the bus, and I'm like, nope, they were just letting me be uncomfortable enough, but actually, like, they were there,
Yeah.
Like,
it's like,
they were probably right outside that room.
It's like, you ever seen those, those movies where they do the, the heroes in this, like, bad situation, then you realize that, then when they go back and do kind of a recap of everything, you realize that, their mentor is standing right there going, no, they're good. Hold on.
Yeah, totally.
And you're like, oh, they were right there all along. Doesn't feel like it.
So,
though.
I mean, at the
Doesn't
time I
feel
did, I was like, you, like, thrown to the cops, the firefighters holding her down, and then the angry wolf, like.
Yeah.
But so he sent me in the room, and she's still just, like, screaming horrible profanities. And then the spit mask, she's able to, like, she's been thrashing her head back, so it worked kind of up her face. And then all of a sudden I got to the end of the bed, and, like, she just made eye contact with me, and it just went silent. Like, the tirade just came to a complete stop, and she just stared me down, and I'm like, oh my gosh.
That's almost worse.
It was, and I mean, there was tons of security and, big dudes in uniform, like, holding her down, but she just stopped screaming, and she said, you, like, I know you, girl. And I was like, I don't think so.
You do.
She said, and then she said, she looked at me, she said, don't I know you from AA? Everyone looked at, like, everyone in the room, kind of, all the security officers.
Like,
and
wow, she just outed
Jess. They looked at me like, huh? Like, like, I thought I knew her, but I don't.
Oh. She only looks sweet and innocent.
Yeah, right? And then, of course, the sweet and innocent side of me, I was like, oh my God, but no, I don't know you from AA. Like, and I wanted to just be like, no, you're so wrong. I'm sorry. Like, that's not me. Please, like, don't let these people judge me. But man, she just knew that we were frickin' buds, and that we were friends. And I had this moment where I was like, you know what? Like, that's what matters. Like, sure, yeah, girl. Like, yep.
Yeah, girl, it's me.
You fall off the wagon, huh? And it was hilarious, because then for the next couple years I worked there, and I'd hear about it. Like, if I wasn't there, she would come in, Nurse Jessie, where's Jessie?
That's funny.
And she'd be really cool with me. If I was on shift and I could take her as a patient, we could avoid the restraints, because she somehow thought I was her buddy from Alcoholics Anonymous.
That's funny. my very first day in the emergency department, we were taking care of this lady, and she looks at me and she goes, "Dude, I know you. You were at that party last night." Everyone's all looking at me like, "Oh, well, all right." And I was like, "No."
Sure.
I'm like, "No." I was like, "No, that wasn't me." And they're like, "She's like, whatever."
Right, man. Sometimes, like, yeah, you cannot. When someone's made that connection, you can barely talk them out of it.
Yeah, no, you can't talk them out of it. It's like
You use it to your advantage.
you're like, "Yep, that was me. Get in the bed."
Right. Yeah. Yeah, it was a good one, huh? Yeah. Okay.
Yeah. Yeah. I had a childhood friend that I had through high school that it was kind of funny. His mom always was just positive that I was going to just drag him to hell and lead him down a terrible road. Well, turns out years later that, I'm working at the hospital where he shows up as a patient very frequently.
Oh goodness.
And he is truly and seriously mentally ill. I mean, and it's sad. It's a really sad case. But we get a call on the ambulance radio saying there's a patient coming in that just put his head through the police window in front of mental health, which is right around the corner.
Ouch.
So they're like, yeah, he's on his way here. He's got lacerations to his head, blah, blah, blah. And they're like, yeah, security and, security standby, restraint standing by. So the guy comes in and he's absolutely out of control, screaming, yelling, hooting, hollering. Like all these cops and security officers are all there holding this guy down. And I walk up and we make eye contact and he's like, "Hey, Kevin, is that you?" I'm like,
Everyone's like,
and he just stops. He just stops everything he's doing. He's like, "Hey, Kevin, is that you?" I was like, "Yeah, it's me, Brian. How are you doing, buddy?" And he's like, I'm doing okay. How are you?" And he's like, starts asking me about my family and just stops.
Yeah.
And everyone's like, "What the hell just happened?" So we get him back to the room and I'm like, "Hey, I need you. I'm going to unrestrain you from the stretcher. I'm going to get you onto this other stretcher. Okay." And he's like, "Oh yeah, sure. It's fine." I go, "Hey, we have to put the restraints on." I'm like, "Go ahead and put them on your wrist." And he was like, "Oh yeah, sure. Okay." He put his own restraints on. And I'm like,
"Sure, bud, no problem."
And he's like, and I was like, "Yeah, we're just gonna leave these on for a little while till you calm down a little bit, and then we're good."
Yeah.
And he was just calm.
Yeah.
It was the craziest
That's
thing.
awesome. But I bet everyone's like, "What the hell?"
They're like, "You are the psych whisperer."
No, this is just my old friend.
Yeah, right. And that's what I said. I go, "Yeah, we're old friends," and that's what did it.
Yeah.
But it was one of those that I was like, "That's certainly not what I expected."
Yeah. Yeah. I think what I learned from that experience is just, I think before that I kind of had this idea like, the specialization was down to like what kind of nurse you were going to be. Like, am I going to be an ER nurse, or I'm going to be an ICU nurse, or I'm going to be, OR.
Yeah.
But there's so many more nuances, and like, just, I think it's huge to kind of like, okay, what does this patient need from me? Do they need me to be, the super assertive, like, this is what we're going to do, or, I'm going to go talk to the doctor and make sure we fix these orders, or do they just need to vent and they need you to sit down in the room for a minute and just let them kind of be heard? Or, do they need a mom? Do they need a mom voice to stop making poor life choices? Or do they need you to be their friend from AA? Like,
good ER nurses can do all of that.
Mm-hmm.
They do it all. They're, they fit the scenario that's needed. And it's amazing how intuitive it becomes that you can figure that out. Because you're like,
gauge that.
Yeah, you know already, like, what do I need to do with you? Like,
mm-hmm.
you just kind of figure it out, or they present themselves somehow. And you're like, okay, if this is what you need to be yelled at, I'll yell at you.
Yeah. Yeah, it's just weird. It's like no one ever taught. I don't think that's taught in nursing school.
No.
I don't even know how you. It's trial by. Yeah, it's kind of. I think it's moments like that kind of teach you. Or
yeah, and I don't even know. Like, you're right. It's not taught in nursing school, but it's never something that's like actually like it's almost something that's unspoken.
Mm-hmm.
And it doesn't get talked about. It's not like you say, oh, hey, let me tell you about this cool Jedi mind trick that you're going to need to know to be in the ER.
It's going to save you time and make people like you.
It's going to save you time, make people like you. You know, you can be an asshole and people will still love you for it.
Right.
And it's not like that gets discussed. It just happens and you just pick it up. And you know, I look at some of the nurses that I watched growing up when I was a tech in the ER, and I, you know, watched these incredible nurses who were just fantastic, and they're so brilliant with psych patients, and that's who I learned from.
Mm-hmm.
And you know, you pick up what you can from them, and you hope that you've learned some stuff, and you know, you hope it works out.
Yeah, completely. It is kind of just that like modeling someone's style, or it's the kind of thing I tend to call like, oh, okay, so you know, nurse I'm orienting, this is not. You don't have to do this. I'm just giving you style points here. You know, like take it or leave it. This may work for you. This might totally not at all.
Your mileage may vary. Here's what works for me.
Yeah, and try to see what works for a lot of different people, and then from that you kind of create your own style.
You end up developing your own style.
Mm-hmm.
Yeah. Interesting. What's the best advice a nurse mentor ever gave you?
Know your shit. He was one of the first nurses that trained me. Like, know your shit, know where it is. And yeah, I think that was some of the first advice I got, and it was you know, can't get any more straightforward than that. But especially when you are starting out and you are able to have someone kind of hold your hand and keep you from falling too far behind, and that is not the time to be delegating. You know, all of those skills, you know, you should be able to do and know where to find things. I know how I ended up getting trauma trained at the hospital. I started relatively quickly, like within a year or two, was I knew where to find stuff, you know. It was slower, so at night I could go in, but I would restock, and oh my God, to this day I can tell you that the Pledgets are like 2 towers over and like about 5
down,
drawers down. Like I just knew where the stuff was, and that just takes a little bit of being proactive and caring. And I also think it's you're being a good coworker, you know, because I know a lot of times, like if I kind of put out a call for help, if you're not someone that is always, you know, delegating stuff just because it's, you know, it's beneath you or whatever, like then people will be much more willing to actually help you out, you know.
Yeah, you're right.
So yeah, know your stuff and know where to find it. I think that's huge.
One of the things,
little thing.
I think that's one of the things that always made the techs in the emergency department so valuable. Is that, you know, they were typically the ones that would stock the rooms, and they would typically be the ones that, you know, they knew where everything was. And even I as a tech, like I knew where everything was, except for, you know, you guys had somebody who would move things all the time.
That was the thing I was going to say. I can tell you where the budgets were at St. Vincent's. I still can't tell you where, like, I don't know, the Kleenex is and 617, because it's moving all the time.
It's because it at the university everything moves constantly. Thanks for that, Mark. You know who you are. But yeah, I remember, you know, as a PRN or going in there going, I have no idea where anything is. You know, that was, I had one of my first traumas in the pediatric ER that I work in now, and you know, they were, you know, I was my preceptor was in the trauma room, and they were like, hey, we need another set of hands in here, and I'm like, let's do this. And I just jumped in and started helping, and then I'm like, where is everything? Because I don't know where anything is in this room. I barely know where anything is in the main emergency department, let alone the trauma rooms. And I'm like, I could start your IV and I get you get your lines secured and stuff, but
hand me the stuff.
Yeah, you just hand me what I need, and I'm good to go. Because I certainly don't know where to find this stuff. So
yeah, and it's huge. I mean, this kind of, I think, ties into another concept about nursing that I think we all know, but no one, it's not taught, or even kind of like put into as something that is really there. But I always find that just, knowing your stuff, knowing where it is, visualizing where it is, okay, they're going to intubate this patient, but what if this goes wrong? Like, maybe it's pretty straightforward airway, so no one grabbed the crite kit, but like, what bad could, where could this go south?
Yeah.
And what would I do, and where would I get what I needed, or what they needed? And that's just kind of like a mental exercise you can do throughout your shift. And it will make you that person that just like, God, how are they always like 10 steps or 5 steps or 2 steps ahead of everyone,
I always appreciated those nurses who were like, always a step ahead.
Yeah, and I love that. It's kind of like a chess game like that, man. Gives me a good feeling when I'm a couple steps ahead,
Yeah, absolutely right. That's certainly the win, where you're like going, okay, if you're a couple steps ahead, you got this.
Mm-hmm.
If you're anticipating worst case scenario.
Yeah, someone asked for something. Oh, like this that I have in my hand that I was about to give you. There you go.
I do happen to have that in my pocket right now.
Yeah. So, yeah, I think that is something. The whole kind of visual. Yeah, you don't even have to physically do something, but you think about it, and your brain makes those connections. And when you actually do have to put it into practice, you'll be able to make that connection just that millisecond faster.
Absolutely. Absolutely. Have you ever witnessed a miracle in the emergency department?
Yeah, well, in flight I did, and we took them to the emergency department.
Tell me about that.
It was we got launched to somewhere in the Taos Ski Basin. It was summertime, or kind of fall. It was just towards the end of summer, and that's a very steep canyon, and that's at the ski basin. That's a sketchy landing zone in the middle of the day. So, and it was dark out. So we tried a couple times, and my pilot was just like, "Nope, this isn't good." So the ambulance came down a little bit further and met us. So we got out and we got into the back of the ambulance, and they're like, so this kid, like, flew out of a car into a campsite. I'm like, what? Like, how old is he? And I can't remember. They had an LMA, or I think we switched him out for a tube. But basically, all we knew was that this emergency room physician and his family were taking a late season camping trip. And all the other campsites were empty. No, it was super late in the season. No one else was camping. And they heard like the sound of an automobile crash and the breaking of glass, and this I don't even know if I ever found out how old he was, really, 9, 10, 11-year-old came barreling through the trees and just landed in the middle of their campsite.
And it was
emergency and the car physicians. Took off. Yeah, and it just happened to be an ER doc. And he had right? He's like, probably like, I can't get away from work.
You're making this up.
No, I swear to God, Kevin. So yeah, this kid basically flew through the trees. We presumed out of a car, and landed in this campsite. And he had obvious, his face was all cut up and obviously head injury. But this physician had he's like, oh gosh, this wherewithal that like a scoop and go. So he picked the kid up and put him in his back seat, and he started driving down the Taos Ski Basin area, and called, once he got cell phone service, called 911, and then kept driving. So he intercepted the ambulance because he knew just time was of the complete essence.
Holy cow.
So, yeah, and that was actually, so I remember going into Trauma 1. That was one of the first times I ever, gave a turnover report for flight, and I'm pretty sure it was Dr. Crandall. I remember his face looking at me like, what? Like, okay, okay, again, we think he's 10.
You have no idea.
He flew into a campsite, we think out of a car. We guessed this was his weight. So this is what we used for RSI, and yeah. And it was end of summer, so of course, like, lots of newbies, and I just remember all these docs being like, well, what allergies does he have? Again, I don't know.
No idea. Not a clue.
So, and the whole miracle part of it was that this kid ended up, like, we did follow up enough to know that he left the hospital, walked out, was just fine.
Did they ever find out what happened to him or how it happened?
Yeah, that was kind of sad. So he walked out into the custody of CYFD, I believe, because he was in a car with his parents who were driving drunk, and he was unrestrained in the back seat, and they somehow, they lost control of the car, and it spun around, and flung him out one of the back side windows. And I don't know if they didn't know or if there was a bunch of alcohol in the car that I heard that they tried to go, get rid of. But the car was drivable, so they fled the scene. And
wow.
The fact that this kiddo, like, just flew through the forest and didn't hit a tree and happened to fly into a campsite that was being, that was an emergency room physician that knew exactly what to do. And just everything was one of those things where just everything lined up, as seamless as possible.
Yeah, how often does that happen? Like,
yeah,
never?
I don't know. I've yet to hear a story that seems like that big of a big of a lie.
Kid, go get a lottery ticket, man! Holy cow!
Yeah, it was one of those where you're like, what was that? Like,
wow.
What? How old is he? What's his date of birth? I don't know.
You're like, don't know. He's a doe. We don't know anything about
him. Does he take
it.
medicines? I don't know. What we gave him?
Yeah, you're like,
I have no idea.
It's one of the hard things about being, flight or pre-hospital is, you know what you know, and you don't always get all the details.
Right. Yeah. So that was definitely, that was one of those things where you're like, God, I just feel like there was probably angels all around that boy. Like, just, nope, let's go a little bit to the left. Don't hit that tree. A little bit to the right. Okay.
A little bit to the right. That's crazy. What a crazy story.
Yeah, that was definitely that was a miracle for sure. Yeah. But then also, I mean, I don't know, just pre-hospital, you see all kinds of things where you're kind of like, gosh, like, no one should have survived that accident. Yeah. And yet everyone did, or things that just really don't look that bad, but, have these horribly tragic outcomes.
Yeah. It's hard. It's sometimes hard to tell. And EMS is the only one who ever gets to see the scene. EMS in pre-hospital is the only one who ever gets to see the scene. They try to tell us in the hospital what exactly it looked like, and you just can't even.
Right. Yeah, you can't ever, I think, really paint that picture.
Yeah.
But it's always good to kind of take an extra moment to wait, like, how far was the, intrusion on the car and where exactly?
Yeah, for sure.
I'll tell you another story that's pretty funny. This happened just recently too. This was I thought it was a complete miracle, and I was completely wrong. So this still hurts my heart a little bit. But I don't know. I guess, like, I've seen enough stuff that I believe there is something else.
Yeah.
Don't necessarily identify with one religion, but I just have seen enough that I believe that there's something after this life. And my husband and I, he's not so sure. So him and I always tend to have these,
deep philosophical debates.
Yeah, kind of like, really, you don't think so? And, no, not at all. So I'm kind of always on this quest to, like, change his mind, probably about a lot of things, but this is one we talk about. And so we took care of this lady that came in from a, like, care facility. She had arrested, I think fire responded. They put an LMA in her, bagged her, several minutes of compressions, and then she came in still being bagged, so LMA was still in place, but they'd gotten ROSC in the field, and she just started to come to, like before the we could RSI her and change out the LMA to a tube. Like she just really came through, and docs were kind of, well, let's see how she does here, and her rhythm looked okay. There wasn't any weird ectopy or anything. So she came to, and like she was definitely confused, but she started clearing more and more. And one of the first cohesive things she started saying, she kept talking about the 2 shots, which Kevin, they had put in ECMO, or they were going to sheath her for ECMO.
Really?
Yeah. So they'd done the venous and arterial line. So that's what I thought. I was like, well, 2 shots. Yeah, they put 2 central lines in you. That's and then she kind of started doing the whole like, oh, it was beautiful. And I was like, what? She's like, well, where was I? I was like, well, I don't know. You tell me. And she just kind of was telling me about this beautiful place and the light and just all these classic things. And I was like, oh my gosh, this is it. Like, you can't convince me anymore that there's not something after this life. This lady had a witnessed arrest and came back, and she still doesn't even know her name, but she can still talk to me about this vivid experience she had. Which my belief came to crashed when we found out that she had just received 2 injections of ketamine for her depression, which I think
may be responsible for the vivid dreams. And
yeah, so I think that's probably what, like, maybe she had a bit of a respiratory arrest, or I don't know, maybe she was just so deep in the K-hole that
yeah.
But yeah, then I was like, oh, okay, or just ketamine. Like, there is something after we die.
There is something after we die.
Ketamine.
It's ketamine.
Oh my God, it just broke my heart. I was like, that's it? It was just ketamine. And at this point, I'd talked to probably a handful of people at work. Like, you won't believe what this lady just told me.
That's crazy. That's funny. We had a patient once when I was working at Presbyterian that came in, and she was a bad asthmatic, and she, the first words out of her mouth are, "Don't let me die." That's always a bad sign. You're like, oh man, don't say that. So she was there, and we were just kind of doing our thing and taking care of him. We were kind of being a little obnoxious at the nurse's station and kind of laughing and joking around, and she goes, "Hey, who is that who is just laughing?" And I go, "Oh, yeah, that was me. Sorry, I wasn't, sorry we were being a little bit obnoxious." So I apologize. And she goes, "No," she goes, I recognize your laugh." And I'm like, okay. She goes, "You were there when I got intubated." And I'm like, oh my God. I'm sitting there thinking to myself, geez, I hope I didn't say anything inappropriate.
Right.
You're like, what did I say? You're like, oh God.
You're like, we never do that. Of course not.
Yeah, I'm like, yeah, we never, yeah.
So this was from another visit, though?
Yeah, from another previous visit. And she
goodness.
told us when she first came in that she was previously intubated. And we were like, okay, let's, get it. And then she tells me, she goes, "Oh yeah, you were there when I got intubated." And I'm like, holy cow. Hopefully that was, hopefully I wasn't inappropriate.
Well, you should remember your laugh.
Yeah, she remember my laugh. I don't know if that's a good thing or a bad thing.
Things to be recognized.
Right. I'm sitting there going, oh my God. Hopefully you don't remember a laugh because I was telling inappropriate jokes.
Right, while we were tubing you. Oh gosh.
So, but you never know what people are going to remember.
Yeah.
You never know what people are going to remember, and that's kind of intimidating. That's like, you're like, sometimes you wish you could just kind of decode like what happened in their brain. Mm-hmm. And I'm like you. I think that there's something else out there. I don't know what it is. I don't know what it is or if we'll ever know. But I always, anytime a patient's talking to me about stuff like that, I'm like, all right, I'm listening. I'm gonna pay attention because I want to see if I can get any kind of insight.
Right. Yeah. I always kind of make a point to kind of see, like, you remember, a couple times. I mean, how often do you get someone who, witnessed arrest, but then, isn't intubated when they leave the ER? It doesn't happen often, but
yeah, it doesn't happen very often at all.
But yeah, the handful of times, it's like, oh, I don't know, like, what do you remember? I mean, I'm just have a personal curiosity about it.
Yeah, me too. I'm with you there. I would love to know, and I'd love to, I'd love to interview somebody who had like that experience, like
right.
Because you hear
make sure they don't have ketamine on their MAR.
Yeah, make sure that it wasn't ketamine induced.
Oh, I was so crushed. It just crushed me.
Like, oh, this is so exciting. Oh, never mind.
Oh, this is so beautiful. Oh, no, she was just in the K-hole.
Chemically induced. I remember, we used to give a lot of ketamine in the PZR. We used to give a ton of ketamine. And before ketamine got as popular as it is now, like it seems like now ketamine is, good for everything.
Pretty go-to, yeah.
Or they they're trying to make it the go-to for everything. But when we used to give kids ketamine, I remember the docs telling us, they're like, like start thinking of happy things and thinking of pleasantries and stuff like that. And sure enough, these kids would come back and see, talk about they're having dreams about, unicorns and Care Bears and blah, blah, blah. And you're like going,
well, I think that's huge. I mean, I actually, I paid for a little Apple iTunes subscription where I can download whatever music for that very reason, because I mean, my sample size of maybe 20, but I swear by it, like if you're going to do a procedural sedation on someone, I'll ask them, like, what do you want to listen to? What's your favorite music? Because there's something about, I think, that auditory component that kind of stays somewhat unaffected. And I'll pop my iPhone in a little biohazard bag and just like tuck it right behind their head.
Yeah, right.
And yeah, I think it seemed to help. Worth enough to spend the $4.99 a month or whatever on it.
Yeah, totally. I think it's totally worth having something. And the pediatric ER that I work at now, we have video, and we have every imaginable video in the world there, and iPads if we need them. So we can give them something, funny. Which is nice.
Kids say that the funniest things though when they're coming out of that though. I remember the first hospital ER I worked at, they did, it's just general, so we did peds too, and we did a conscious sedation on this kiddo for a ulnar radial fracture, and so he came out of it, and I remember he was probably 8 or 9 telling his mom, I want to do that every day. God.
You're like,
oh, God.
Let's not do that.
No. That's a poor choice. No, let's not do that every day.
Maybe not.
Like, good luck to you in 10 years.
Future drug addicts Anonymous.
I feel like we just opened his world up. He's like, yes, I love this. I'm like, oh no.
You're like, oh,
sorry,
God.
Mom.
Yeah, sorry about that. Didn't mean to ruin your child there.
Right.
So that's funny. So the last question I always ask, and I'm going to ask you, is give me 3 things an ER nurse should remember and 3 things an ER nurse can just go ahead and forget.
Well, I think the you see something, you say something. That's number 1, my advice. I would say, know your stuff, know where to find it. Like the devil's in that detail. But if you can find a way to cut off just a couple seconds in getting a supply or knowing where it is or having to find someone who knows how to get it, like you will just have, those are the little time savers that make your care just so much more seamless and make your days feel less crazy, when you can when you can minimize your actions, or how many steps you have to take to get somewhere.
Yeah.
So don't underestimate that, the importance of kind of reflecting on that. Gosh, I think just the to remember to just constantly be reevaluating. Like, it's such a dynamic environment, and I think with the presence of electronic medical records, like, I'm really glad I got to experience the paper charting for a couple years.
Yeah.
I feel like it made you think in a different way, that maybe the check boxes and just the digital order sets don't make you think or have to be as like aware or like critical about what's going on. So really, like, work on critical thinking. And I always tell people when I'm orienting a new nurse, or when they start to get flustered, it's just like, like, next best step. If you make a list in your head of 10 things that you're going to do in the next hour, like, by the time you get to 3, you're misprioritizing, because, like, the game's changed.
Yeah.
So don't even waste the time making a list. And man, sometimes, like, sometimes it's just the next one step. Like, what,
Yeah, what are you going to do now?
Yeah. And now. And, ABCs, you reassess your people, and then what is the next best intervention?
Yeah.
So, yeah, next best step, and keep that list to 3 or less things.
Yeah. 3 things to forget?
I know I've heard this on the podcast before, but I think it's because it's so important. Like, forget the ego.
Yeah.
Be the nurse that calls out the lack of rectal tone right after you pushed rocuronium. Like, be okay with, like, being that guy, with, like, being loud and proud and saying some dumb stuff every once in a while.
Yeah.
I think I mentioned this before with the know where your stuff is. Like, I think new nurses, like, forget about delegation. Like, at least at first, at least when you're working with someone, at least for the first little part, don't delegate something unless you are comfortable doing it yourself.
I agree. I don't know how many times I see people, say, "Oh, I want to get the tech to start my IV." It's like, no, you don't get to do that.
Well, yeah. Also, it's like, man, if you go in the room with all your stuff, like, you can have your pretty much entire assessment, past medical history done, and an IV started that you put in.
Yep, you're absolutely right.
So, yeah, I think, I know that coming into that environment with the ER, it's so overwhelming. And yes, delegation is a skill that is an absolute necessity. Like, it takes a whole team to do this job, but especially when you're starting, like, don't even think about that.
Yeah, I agree.
And then here I'm sitting in my guest room in my office, and made me think of, sell those nursing textbooks back when you can. Because you will never. I still have textbooks that I'm like,
you're looking at them right now, aren't you?
Yeah, I'm staring at them. I'm like, God, you need to recycle those, Jess. Like, you're never going to need your adult nursing care one.
Yeah.
And even times you go back to look at it, it's like, no, I need some more explanation. So, yeah, sell that back when you can, while you still can.
Get rid of those immediately.
There's great resources out there. I love the, oh gosh, I'm going to have to pull it out and see the author. Even for ICU nurses, the ICU Bible,
Uh-huh.
the ICU book by Marino. Even though it's, obviously a different department, I found that this is one of my favorite resources. I still pull it out. And yes, it's critical care, so of course it's not. But as far as, like, the why questions that I think new nurses should hopefully be asking, like, well, why does it do this? Or, why do I have to worry about potassium when I hang insulin? And for me, especially, like, I that's how I learn the best. If I can at least understand some of the concept of, like, okay, why? What is going on here? What's happening?
Yeah.
So much easier to retain the information.
Absolutely. Absolutely. I think if you know the why, you can figure out the how.
Yeah. Yeah, and it helps you, be that critical thinker that when presented with a novel situation that you haven't seen before, you're like, okay, well.
Yeah.
So,
You're absolutely right.
Be that, I'm a mom of 6-year-old twins and one that are the youngest about to turn 3. So, like, be the toddler that's just like, why? Well, why? But why? And also look it up, like that was always for me a big thing. So if someone tells you something, it's so easy to just, okay, But if you actually have to find it in the book yourself or find it, there's so many resources online now.
Absolutely.
If you have to put in the legwork, like that's when you're going to remember something.
It's true. I think I always tell people, like, remember to look stuff up, like keep notes and be like, okay, what didn't I know today? And then I remember, my first year as a nurse, I don't know how many times I'd come home and like look stuff up or read stuff or be like, okay, I got to take a look at this. Because it was
you should
always,
be reading more that first year than you did in nursing school.
Yeah, because it's always like I there's so much I didn't know.
Mm-hmm. And then you tie it to a patient, I think also to tie it to a real experience, and then you have to be, or you don't have to, but I don't know. I think the best ER nurses come from that drive that I may be brand new, but I want to know how to do this better, why I'm fascinated by it, and I'm motivated by it, and I'm willing to like kind of just jump down the rabbit hole, and because it will start coming together and making sense.
Yeah, and it it takes a little while, but it'll start to form and be like, oh, okay, now I get it. Because now I as a more experienced nurse, I understand concepts I never understood. In nursing school, I never understood when I was a first brand new nurse. There were things that I was like, okay, I'm doing this because this is what I'm supposed to do, and now I'm like, now I get it.
Like, oh, that's why. Yeah. So totally geek out and dork out and ask all of the why questions.
Yeah.
But then also don't forget that just because you feel like maybe you're starting to get a grasp of things, that you are not missing not all. Everything.
Never think you got it all figured out.
Right. Just because you can explain it, like, doesn't mean you quite get it.
Yeah. I remember sitting in a lecture. I remember at one of the best ACLS classes I ever took. It was like there was like 3 of us there in this ACLS class, and we just sat down and had a conversation about resuscitation with somebody who was much more experienced than me. It was a paramedic. He was a paramedic who was teaching ACLS, and he was just so good and just understood at a deeper level than I did at the time, and it was just he was just awesome, and it was one of the best classes. I learned so much just sitting there having conversations.
Yeah, and I think I think that's huge. I mean, like in ACLS, you can approach it like, oh, I'm just going to memorize the the protocol, or okay, what do we do next, or what? But like, and I know that sometimes this is not how nursing education is always approached necessarily, but there's no reason, like, you can understand like what receptors is this drug working on, and why does that even matter? Look that stuff up. Like, I think nurses are all the better for when they have a solid kind of understanding of the physiology of what the interventions they're doing, and that will stick with you. You can not really come across that drug for a while, but then next time you see it, it will be in a completely different patient, oftentimes in a completely different scenario, but you'll have that knowledge. It'll make you a better nurse, better care provider, more safer.
Yep, it's true. Well, gosh, we didn't get through all the questions, but we got through some.
Yeah, I hope your poor hard drive.
This was good. No, this was good. This was a good conversation. All right. I've taken up enough of your time.
Oh, well, I have given you too much stuff to edit and listen through, but I hope we've got some good stuff.
This is really good. I really enjoyed it. It was a lot of fun. I'm so glad we got to do this. This was good.
Yes. All right, Kevin. Well, I'm glad I got to see you on my, almost or second or third to last day there. Almost,
I know. I'm sorry we didn't get a chance to talk, but you were
way
too busy.
I kind of turned around. I was like, where is he? Get him some green scrubs. Come on.
Right. Anyways, I'm going to let you go. I look forward to hearing
Kevin.
What's next for you. And if there's anything I can do to help you, please let me know.
All right. Thank you, sir.
I'll
talk to you soon.
Thanks for listening to the Art of Emergency Nursing podcast. Make sure to subscribe to the podcast and follow us on Facebook.